The purpose of this video is to introduce the concept that fetal heart rate patterns are more informative than fetal acidemia. Traditionally, fetal heart rate patterns have been used to predict fetal acid-base status at the time of testing. It is a general belief that fetal acidemia is a common final pathway to fetal death and, in many cases, to fetal CNS injury. However, after extensive clinical use of electronic fetal monitoring, it appears that there are certain fetal pathophysiological processes associated with significant Category 2 or Category 3 fetal heart rate patterns, even in the absence of fetal acidemia. The objectives of this video are: number 1, provide an overview of the most common fetal pathophysiologic processes associated with abnormal fetal heart rate patterns without fetal acidemia and discuss possible mechanisms. Number 2, alert clinicians that abnormal heart rate patterns may not be necessarily the result of primary uteroplacental insufficiency as traditionally taught, but such fetal heart rate patterns could reflect a specific underlying fetal pathophysiologic process associated with adverse neonatal outcome independent of fetal acidemia. Number 3, provide evidence that Category 2 or even 3 fetal heart rate patterns may provide insightful information and outcome prediction for the fetus even in the absence of fetal acidemia. And number 4, challenge the traditionally held belief that acid-base status should always be the gold standard outcome for assessing the clinical relevance of fetal heart rate patterns. The fetal pathophysiological processes include fetal infection and or inflammation, fetal anemia, fetal heart disease, and fetal CNS injury. The common characteristic of these pathophysiological processes is that their associated fetal heart rate patterns are linked to adverse neonatal outcomes despite the absence of acidemia at birth. The most common of these processes is fetal infection inflammation, which should be suspected in patients with abnormal fetal heart rate patterns in the clinical scenarios of premature rupture of the membranes, prolonged rupture of the membranes, or preterm labor. A review of the relevant literature reveals that in such cases there is fetal tachycardia, increased in fetal heart rate baseline, minimal or absent variability, and severe variable decelerations. The mechanism or mechanisms by which fetal infection/inflammation may cause abnormal heart rate patterns in the absence of fetal acidemia include: number 1, increased fetal metabolism can lead to fetal oxygen demands increase with relative tissue hypoxia that can cause malfunction of fetal CNS centers that control fetal heart rate. Also, systemic hemodynamic and circulatory changes could end up reducing the tissue oxygen delivery at the periphery, and also vasoconstriction of umbilical and chorionic vessels due to inflammation. Fetal anemia may be suspected in the presence of abnormal heart rate patterns when patients have maternal red blood cell alloimmunization, in the setting of fetal-maternal hemorrhage, fetal parvovirus B19 infection, and in some cases of decreased or absent fetal movement. A review of the relevant literature reveals that sinusoidal fetal heart rate pattern is rare and it is observed only in cases with severe fetal anemia, whereas lesser degrees of anemia are associated with decreased fetal heart rate reactivity and baseline variability, late fetal heart rate decelerations, tachycardia, and prolonged fetal heart rate decelerations in the absence of fetal acidemia. The mechanism that fetal anemia may cause abnormal heart rate patterns in the absence of fetal acidemia may be related to the low fetal blood oxygen content, resulting in tissue hypoxia and malfunction of the CNS centers that control fetal heart rate. Fetal heart disease, either arrhythmias or congenital structural disease, are associated with abnormal fetal heart rate patterns in the absence of fetal acidemia. Review of relevant literature reveals that bradycardia and tachycardia are seen in bradyarrhythmias and tachyarrhythmias respectively, whereas fetuses with congenital heart disease, even in the absence of arrhythmias, may present increased rate of minimal or absent fetal heart rate baseline variability, severe variable decelerations, prolonged decelerations, and recurrent late decelerations. The mechanism by which congenital heart disease can cause abnormal heart rate patterns in the absence of fetal acidemia include placental vascular malperfusion lesions and also abnormalities in the impulse conduction system, increased pressure in ventricles leading to overload, hypertrophy, and aberrant electrical conduction. Fetal CNS injury could cause abnormal fetal heart rate patterns in the absence of fetal acidemia. Fetal heart rate patterns compatible with CNS injury include absent fetal heart rate variability, severe bradycardia, decelerations with absent or minimal variability, sinusoidal fetal heart rate pattern, sawtooth fetal heart rate pattern, and wandering baseline. Review of relevant literature reveals that fetal CNS injury is detected much more frequently by abnormal fetal heart rate patterns as compared to fetal acidemia. In general, fetal CNS injury detection of fetal CNS injury by fetal heart rate patterns is 82% versus 47% by fetal acidemia. Also, detection rate of cerebral palsy, similarly, by fetal heart rate patterns being abnormal, is 81% versus 46% by fetal acidemia. The mechanism by which CNS injury can cause abnormal fetal heart rate patterns is, of course, systemic or local injury, which can occur antepartum or intrapartum, affecting the cardioregulatory region in brainstem, posterior hypothalamus, and medulla oblongata that control fetal heart rate. This slide shows the fetal pathophysiological processes associated with significant Category 2 or Category 3 fetal heart rate patterns in the absence or prior to the development of fetal acidemia with the possible pathophysiologic mechanism.